This episode was recorded in Q4 2025. The information provided in this podcast is for educational and informational purposes only. The views and opinions expressed by hosts and their guests are their own and do not necessarily reflect those of the Irish College of GPs. By listening to this podcast, you acknowledge that no party is liable for any direct or indirect consequences resulting from the use of the information provided. More information can be found in the show notes or at irishcollegeofgps.ie.
Most of the time when we're trying to improve quality of care, it represents an increase in workload. But there's actually the potential with assessing and diagnosing urinary infection that can reduce workload. So that's a real treat where we can do things better and do things smarter and make things a little bit more efficient.
Hello and a very warm welcome to the GP podcast from the Irish College of GPs with me, Dr. John Maher. Today I'm joined by Dr. Scott Walkin to discuss antimicrobial management of urinary tract infections in primary care. Here's Scott.
Now, I'm a GP based in Mayo, and I also work as the clinical lead for antimicrobial resistance and infection control here at the Irish College of GPs. I have a role also teaching, and I am an assistant scheme director of the GP training scheme in Sligo. So they're my three roles.
When it comes to antimicrobial stewardship, Ireland currently ranks quite highly in some respects, with the joint third lowest fluoroquinolone consumption and fifth lowest ratio of broad to narrow spectrum antibiotic use among 29 EU and EEA countries. However, Ireland remains ninth highest in terms of overall antibiotic consumption in primary care in the EU and the EEA. And meeting the EU Council's target of a 27% reduction in community prescribing by 2030 remains a significant challenge. And of course, UTIs represent a common presentation potentially requiring antibiotics in primary care. So during our conversation, Scott provides a comprehensive overview and a rational approach to management of acute and recurrent episodes, including in such cohorts as those residing in long-term care homes and those with catheters. He also reviews when the dipstick can be a useful aid to diagnosis and, equally importantly, when to skip the dip and when to send samples to the lab. Scott also provides an overview of non-pharmacological management options. As usual, you can check the show notes for relevant links to articles supporting today's episode, as well as chapter markers to help you navigate your way through the episode. Scott began our conversation today by discussing how to make the diagnosis of UTI.
So it's actually very much a case of starting with the history, and I think the most important things in terms of diagnosing urinary infections are the symptoms of dysuria, urgency and frequency. And the absence of a vaginal discharge also is an important clue, because you need to think a little bit more broadly if there's a vaginal discharge. So they're the key symptoms on taking a history. Now, when it comes to examination, I see the history as the most important part of diagnosing the common day-to-day urinary tract infections, cystitis or lower urinary tract infections that we see all the time. I think the examination checking for loin pain or loin tenderness, checking for fever, that will help us consider whether there's a possibility of acute pyelonephritis. So if people are systemically unwell, or if they've rigors, or if they're having high temperatures, that very much raises the question of the less common but very important acute pyelonephritis. So they're the most important elements, really. History to decide if it's likely to be urinary infection, and then the examination, which the vast majority of the time is to outrule acute pyelonephritis. And of course, we all know vital signs are vital, so checking the vital signs can be very helpful just to consider the possibility of sepsis. Thankfully rare, but important when it happens. You might have noticed I haven't mentioned dipsticks. So dipsticks do have a role, that's for sure, but they are often overused. And there is a risk of false positives with the dipsticks. And the problem with the false positive is that, it forces us, it really makes us want to treat that dipstick rather than treating the patient. Okay, so dipsticks probably are most important in non-pregnant women under the age of 65. In other cohorts, the risk of false positives goes up substantially. So, for example, people with an indwelling catheter, it's really likely that they'll have abnormal dipstick urinalysis, whether they have infection or not. People who are in residential care facilities, again, they tend to have a high false positive rate. So in other words, the dipstick will be abnormal even in the absence of infection. And the other group is people over 65. Dipsticks really are not very helpful because the false positive rate is so high. So they're the areas that we can get caught out a little bit. There may well be very good reason to check dipstick urinalysis in those cohorts. So, for example, if there's hematuria or suspected hematuria, but it is not a useful tool to diagnose urinary infection. Similarly, pregnant women, dipstick urinalysis is not helpful for the diagnosis of urinary infection in pregnant women. They really need to have a urine sent to the lab when urinary infection is suspected. But of course, dipstick urinalysis is important in the assessment of preeclampsia. So dipsticks have their role, but it's largely, really it's in non-pregnant women under the age of 65. Otherwise, the false positive rate is way too high. So it's back to the history and the examination. There are circumstances where the microbiology lab can be helpful. So, for example, sometimes it's referred to as the 8 Ps of testing P, right? So, if people are pregnant and we suspect urinary infection, we should be sending a sample to the lab. Sometimes it's difficult in general practice. Maybe we don't have transport for the sample to the lab, but really, ideally, we should be sending a sample to the lab. If there is suspected acute pyelonephritis, so as you know, these are a group of people who can get really sick, and if they are not responding to treatment, it's really helpful to work out, well, why is that? And maybe it's because they have an infection caused by a resistant organism. It's the only way we're going to know if what their infection is sensitive to is by sending a sample to the lab. If people have persistent symptoms and they're not improving, or indeed if they have a poor response to initial treatment, well then they should have a sample sent to the lab. If you know that a person has had urinary infections in the past that have not responded for previous resistance, it's helpful to send a sample to the lab for them. And then people with prostates, men in other words, but for the acronym, people with prostates. So we really should be sending samples to the lab for everybody with a prostate. In pediatrics, we should be sending a sample to the lab. And then people with urological structural abnormalities or urological problems, so problematic plumbing. If people have stones, if they've an obstruction for some reason, for example, if they have prostatism that's causing an obstruction, maybe people with neurogenic bladder, or if they've, maybe congenital abnormalities resulting in reflux, are also people that are plumbed, people with an indwelling catheter. So they're the 8 Ps of testing P.
Okay, so just as a recap, we have pregnancy, suspected pyelonephritis, persistent symptoms or poor response, past resistance or recent antibiotics, people with prostates, so men, pediatrics, and then problematic plumbing, and people who are plumbed, so people with catheters, in other words.
That's it.
Okay,
yeah.
That's very useful. Thanks for that. And could I ask you maybe one or two simple questions, if that'd be okay? In your own mind, if you do decide to dip, do you have a hierarchy of what findings on the dipstick are more suggestive than others in terms of the possible presence of a UTI?
Yes, so if people have nitrites on the dipstick and pus, or if they have nitrites and blood, that points to a urinary infection, in the appropriate clinical context. If people have pus without nitrates, there is a reasonable likely, around a 50-50 chance that it is due to a urinary infection. again, depending on the clinical context. So they're the most important findings. We have some information about this that's available on the urinary section of antibioticprescribing.ie. So there's lots of resources there for people if they want to look them up.
Now we've kind of delineated between the various categories of people who may present and the different Ps to look out for. Could we move on now to management and which antibiotic might be appropriate in which setting?
Okay, so in general, for the common type of infection that we see, so cystitis, a lower urinary infection in the non-pregnant situation, the first line treatment is nitrofurantoin. Okay, now nitrofurantoin is concentrated in the urine. So if it's a straightforward lower urinary tract infection or cystitis, that's exactly what you want. However, if there's any suggestion of acute pyelonephritis or, for example, prostatitis, where the infection is within the tissue, nitrofurantoin does not penetrate well into tissues. So what that means is that you might have a culture and sensitivity report back from the lab, which tells you that nitrofurantoin would be expected to work, that it's an infection responsive or sensitive to that. However, if the infection is acute pyelonephritis, if it's within the parenchyma of the kidney, the nitrofurantoin will not penetrate into the kidney and will not treat it. Okay, so that's just one thing to be careful with when and again, that comes back to making the diagnosis clinically and tailoring the treatment depending on what you think is the most likely explanation. The other thing just to think about with nitrofurantoin is that it's available in two versions. So there's the rapid release. The only brand that's available in Ireland is Macrodantin, and that's at a dose of 50 milligrams 4 times daily. Now, sometimes 4 times a day medications are a bit inconvenient, and a twice a day treatment is much more straightforward. So Macrobid, BID, the American for twice daily, Macrobid 100 milligrams is a twice daily version. So if we are prescribing nitrofurantoin, we should prescribe it either, if we want the slow release version, Macrobid, we should specify Macrobid on the prescription. If it was not specified, hopefully the pharmacist will catch that and will dispense the appropriate medication. But to reduce the risk of medication errors, it is worth specifying Macrobid on the prescription. Final thing I might just say, well, maybe two things. The standard duration of treatment for urinary infections, for lower urinary tract infections or cystitis, is for 3 days. That can be extended to 5 days if there's a poor response, but 3 days generally works absolutely fine. And the final thing about nitrofurantoin is that it should be avoided in people with an eGFR of less than 30.
And again, going back to antibiotic prescribing, that's one of the reasons why I like it so much, because I don't have the cognitive burden of trying to remember all these things, because everything is put so succinctly on the guideline.
Yeah, I think one of the things actually that's helpful, I would argue, about antibioticprescribing.ie is that the guidelines are updated regularly. If you remember them and learn them off by heart, when they're updated, you could miss it. So I think there's a lot to be said for referring to it frequently. We deliberately write it in a way that makes it easy, we hope, to use at the point of care. And that is one of the reasons, to allow people to come back to it so that they don't have to learn it off. And if they don't learn it off, well, then they'll be correct when they look it up, because they are updated regularly.
Okay, that's useful to know. So moving on then from nitrofurantoin, you mentioned a couple of alternatives. Would you like to go into any detail on those, on the trimethoprim or on the cefalexin or the fosfomycin?
So trimethoprim, there's a lot of resistance to trimethoprim. Great drug in many ways, but the problem is that the majority of urinary infections are resistant to it. So that's a medication really that should only be used if you know that the infection is sensitive to it or is very likely to be sensitive to it. There's quite a geographical variation on resistance patterns to antibiotics, and none so more than with trimethoprim. So if it's likely to be a sensitive infection, well and good, and you'll probably have a handle on that from previous culture results that have come back from the lab. So cefalexin, it's an alternative first-line treatment. Again, all of the details are in the urinary section of antibioticprescribing.ie.
And just as a reminder then, when we're thinking about culture, we're going back to those 8 Ps that we've already mentioned earlier on.
That's right, yeah.
So that's our acute presentations. Could you move on then a little bit around recurrence, Scott, please?
Yeah, so this is often a really difficult area because the symptoms are so frustrating. And of course, as a professional prescribing, we want to try and minimize the amount of antibiotics we're exposing our patients and their microbiomes to. So there's this balance, isn't there? Trying to minimize the risks of antibiotics and maximize the benefits. One of the first things to think about is to consider a differential. The genital symptoms of the menopause can commonly, number one, mimic urinary symptoms, but also can contribute to the development of recurrent UTIs. So a non-antibiotic approach that's really helpful for reducing the risk of recurrent UTIs in the appropriate demographic is the use of local or vaginal estrogens. Okay, so then the other non-antibiotic approaches that have evidence supporting them. There's one trial that has looked at the effectiveness of increasing fluid intake, and that found that there was some evidence for it, but that's just one trial. Having said that, it's a very low-risk intervention. It's a safe thing to do. So increasing fluid intake can help as well. Depending on triggers, sometimes if people have post-coital cystitis, voiding after intercourse can reduce the chance of recurrence. And probably the main other non-antibiotic approach to the management of recurrent urinary infections is methanamine hippurate. So there's some evidence supporting that.
And would you mind speaking a little bit to that? What's the formulation? How is it given?
Okay, so methanamine hippurate, it's a tablet and it's 1 gram twice daily. What it does is in an acidic environment, it releases formaldehyde and that has an effect on any bugs or pathogens in the bladder. Now, it takes some time in the bladder for that to happen, which means that methanamine is not suitable for people that have catheters in place because the urine won't be sitting in the bladder for long enough for the methanamine to be metabolized. And similarly, people that have urinary incontinence, it's not very helpful for that group. But other than that, it's a very helpful option to trial for people with recurrent infections.
And how long would you give that for?
Well, I think with any prophylactic agent for recurrent UTIs, they can be trialled for a period of 3 to 6 months. And I think it's worth trying to stop them then. Certainly when antibiotics are used for recurrent UTIs, they should be stopped after 3 to 6 months. Again, it's because there are risks and benefits with antibiotics. And the longer somebody is on the antibiotics, the more likely resistance is to develop. So trying to minimize people's exposure to antibiotics will reduce the risk of resistance developing. If I'm using an antibiotic for prophylaxis, usually what I'll say is, look, we'll try this for a period of 3 or maybe 6 months, and that's generally enough time to allow the lining of the bladder to settle down, and then we'll stop it and we'll see how things go then.
And do you have your 1 or 2 agents that you prefer in terms of prophylaxis if you are going to go down the antibiotic route?
Well, my preference is not to use antibiotics, but if I am going to use antibiotics, I really don't like to use nitrofurantoin, to be honest, because the problem with it is it has pulmonary and hepatic toxicity. So I really try not to use that if I can. Sometimes, if you're lucky, if there's trimethoprim sensitivity, that's a really nice one to use. But of course, the preference is to try and avoid the use of long-term antibiotics if possible. So again, for details on which agent to use and which dose to use it at, you'll be able to find those in the prophylaxis section of the antibioticprescribing.ie website. There are also other resources there, such as the Skip the Dip position statement on the use of dipsticks, and also the decision aid in relation to urinary infection in residential care facilities.
Okay, and we might move on to that section next, which will be people in long-term care facilities and catheterized patients.
Sure. So if somebody has a catheter in their bladder, it will cause some irritation in the lining of the bladder, and their dipstick urinalysis will be abnormal. Okay. The people with indwelling catheters, it sometimes can be quite difficult to determine, well, is it an infection or is it not an infection? A general deterioration might be because of a urinary infection, but equally it could be for a number of other reasons. I think before jumping in and automatically treating for a UTI, we should think about other causes, which can be summarised as pinch me. So we've got P for pain. So IN stands for infection. The C stands for constipation. H stands for hydration, but it's also worth thinking about other metabolic abnormalities, hyponatremia, hypoglycemia, so other metabolic abnormalities, PINCH, M for medications, so anticholinergics, any new medication, opiates, benzodiazepines, anything can cause a deterioration like that. And the last one is environment. So the person who has lost their hearing aids or glasses, or the person who's moved room, or maybe they're new to a nursing home, or maybe they've moved from the nursing home to the emergency department and they become really confused and agitated. So pinch me is worth considering. And if people are not improving after treating presumed causes of their deterioration, well, then it's worth reevaluating whether an antibiotic for a urinary infection is needed.
And when it comes to, let's say contact from a nursing home, for example, part of the assessment, I guess, would be the quality of the sample and ensuring that the port is used rather than the bag itself. Would that be fair?
That's right. So if it's appropriate to send a sample to the lab, what we should do is take it from the catheter port, because anything you take from the bag will not give a true reflection of what's going on. Almost all of these samples where the catheter has been in for longer than a month, you can expect to find abnormalities that have grown in the lab. So you expect that. But you stack the odds in your favour of isolating the organism which is causing the infection by sending a sample from the port.
Okay, that's clear. Can I ask, going back now to the uncomplicated versus complicated, do you have an idea around when you consider an emergency department assessment for an evolving pyelonephritis, for example?
Yeah. So the worry here, of course, is sepsis. Now, not every acute pyelonephritis needs to be referred into hospital, but a lot of them will. They can get sick very quickly. So if you have a younger person who is healthy and doesn't have other medical comorbidities, and they're not on maybe immunosuppressant medications, if everything else is okay, they are often amenable to an initial trial of treatment in the outpatient setting, in the GP setting. But if you've got somebody who's a bit older, maybe they're on methotrexate or another immunosuppressive agent, if they have diabetes or other medical comorbidity, you really have to think very seriously. You'd want very good reason not to refer them in. It may be that their ceiling of care does not include referral to the emergency department. That's fine if that decision has been made. But people with comorbidities are at high risk of adverse outcome from acute pyelonephritis.
And as you said, people can deteriorate at any age, really, towards a sepsis. Do you give patients any kind of an idea around when they can expect to see an improvement in their symptoms once they commence their antibiotic?
I mean, I completely agree with you, and I think that's why safety netting is really important. I give them written safety netting advice. An antibiotic, really, you should be seeing an improvement after about 24, 36 hours.
And certainly no deterioration in that time frame as well.
If there's a deterioration, I think really they should invoke that safety netting advice and return to you, or to go to the emergency department. That's really what's likely to be needed at that stage. They can get sick very quickly.
And as a final reminder, just to hammer the point home, antibioticprescribing.ie is our friend.
great website, I think. I have a conflict of interest there. I contribute to it, but yeah, great website, I think, yeah.
Okay, Scott, thanks a million for speaking to me today. Really appreciate your time.
It's been a pleasure. Thanks for having me along.
Many thanks again to Dr. Scott Walkin for taking the time to speak to me today, and thanks also to GP and pharmacist Dr. Paul Ryan, antimicrobial pharmacist Shah, and clinical microbiology SPR Dr. Robyn Traynor for their input in today's show. Further reading can be found via the Irish College of GP's website, including an infection control section which aims to improve awareness and knowledge, enhance surveillance of antibiotic resistance and antibiotic use, reduce the spread of infection and disease, and optimise the use of antimicrobials in human health. The Irish College of GPs also recently published an adult sepsis general practice update in 2024, again available on the Irish College of GP's website. Relevant links to articles and websites supporting today's episode can be found in the show notes accompanying this episode, as well as chapter markers to help you navigate back to areas of interest to you. If you have any comments or feedback on today's show, or indeed any suggestions for future topics, please drop us a line at podcast@icgp.ie. That's it for today. Many thanks for listening, and until next time, take care.